Bhaskar sir, are we good to start?
Yeah, let us start the program. Yes.
Yeah. Gayatri, you can stop screen share. I'll tell you again when to put it up. Yeah. Good morning, everyone. Namaste. And welcome to today's IAP Twin Cities branch PG Clinics. We've been able to conduct this PG Clinics every month and very interesting case discussions on a particular case for a full 1.5 hours. This is a golden opportunity for all the postgraduates to understand the exam-oriented discussions, and we have very experienced examiners who will share the key questions which are asked in the exams and also very relevant to practitioners as well, because this is how the case is usually approached when the child comes to us. IAP Twin Cities branch, thank you for all your cooperation and support. Please join us for the upcoming Central IAP workshops and also other activities. I'll now request our president, Dr. Sunkoj Bhaskar sir, to please give his inaugural remarks. Over to you, sir.
Yeah, thank you, Dr. RSV. It seems you're enjoying the nature. I feel you're not in Hyderabad. It seems you are in...
Yes, sir. Joining you from the hills of Araku. And I think that's the advantage of having technology, that it's able to connect all of us together. Over to you, sir.
You're a natural lover, because 2 weeks ago you were there at Maredi Milli, the thick Rampa Chodavaram forest. Anyway, distinguished faculty members, respected seniors and participants, I sincerely welcome you all to this uninterrupted 9th edition of monthly virtual PG clinics being organized by IAP Twin Cities branch. I sincerely acknowledge the presence of Dr. Tudum Anand, Professor Tudum Anand, who is there with us among the participants. It gives me a great pleasure to see the seniors along with the youngsters and the postgraduate students. And I'll briefly tell you about the history of this e-learning, which we started by IAP Twin Cities branch. In 2020, when we had this COVID-19 pandemic, so it was completely closed. Hospitals were not functioning properly. Academic institutes were not working. Then we started in the month of April or May 2020, these Iaptcb e-learning programs. We had done not less than 80 webinars, whether it is symposia or PG clinics or IAP clinical presentations. And it was a wonderful experience, and I should thank Dr. Sri Nagesh, our endocrinologist, Srinivas Murki, our neonatologist, along with our Dr. RSV, who was a very, very resourceful person to do these all digital communications and organizing these webinars, particularly technical side. I'm sure this e-learning, these PG clinics will work as an adjunct to your regular academic programs during your training at your respective centers. And this e-learning has brought in a lot of changes. See, such a nice, beautiful, sunny Sunday morning, we are all sitting comfortable at our home. We could manage our time so well. We could overcome the traffic hazards. We are with our family members. Despite all these things, again, our focus is about learning the things from the experts. I'm sure this is going to be a very interesting case because it's a neurological case. And I feel it's the best of all the cases will be the neurological case for discussions. I should thank Dr. Devraj, the professor. Earlier he served as professor, and as well he was the superintendent of Neelafar Hospital. Very simple, humble, but academically very sound, knowledgeable person. Thank you, Professor Dr. Devraj, for accepting our invitation. I'm thankful to our Suresh Panaganti, instantaneously arranged this long case when I requested him a few days ago, with the help of his colleagues, Dr. Jeevan Reddy, Dr. Samatha Reddy. Really, they were very attentive, very responsive, and very enthusiastic. My sincere thanks to Dr. Jeevan, Dr. Samatha, and the luckiest person among all these during this webinar of PG Clinics is none other than Dr. Bhanudeep Hosur, because he is going to have a great experience. It will boost up his confidence for his real final PG examinations. With these few words, I would like to make an announcement. This particular one program, Iaptcb, in association with PATS, is coming up. That is Speak and Inspire. I know you're all very talented people, digitally very having sound knowledge. Even then, probably we may need to improve our skills of public speaking, public academic speaking, and talent. If you know, there are some speakers academically very sound, but they find difficult to communicate and convince. And there are very few people who are not very strong in academics, but they have the communicating skills. They speak so well for 20 or 30 minutes, they get big applauses. But when you look back at the academics, the content may not be so much. So with this background, I request all the youngsters and whoever is interested to participate in that. We have a professional trainer on the day. I'm sure he will improve our further professional skills, particularly communications and public speaking. With this, I wish you all a great learning experience. And once again, I thank all the participants, because it is you who inspire the organizers, who create enthusiasm among the faculty members. With these few words, I sincerely thank you all. And I request Dr. Devraj to say a few words and conduct the proceedings along with Dr. Jeevan Reddy, Dr. Samatha, and Dr. Bhanudeep. Over to Dr. Devraj.
Good morning, everybody. I'm Dr. Devraj, Professor of Pediatrics from Shadar Medical College. And I'm very much thankful to the IAP Twin Cities branch to give an opportunity to participate in the case discussion. It's a very, to outset, it's a very interesting case also. And definitely we'll have a good interaction. Thank you, Dr. Bhaskar.
Thank you, Dr. Devraj. Thank you very much. Now, Dr. Jeevan, would you like to say a few introductory remarks?
Yes, sir. Good morning, all. Thank you for the opportunity. It's honor to present our moderator session in Iaptcb clinical meetings, and it's definitely going to be a good session. So we'll learn some things from this also, and I'll ask Dr. Gayatri to start the proceedings. Thank you all.
If Dr. Samatha would like to say a few words, she's welcome.
Good morning, all seniors and my colleague. Today we are going to present a case about a neurodegenerative disease. Actually, it's a very interesting case. We are very pleased to present this case. Thank you for giving us this opportunity. Gayatri, please present.
I sincerely convey my apologies to our expert, another lead discussant of today, Dr. Just a moment, please. Just a moment. Dr. Bhanudeep is another lead discussant. He will be participating along with Dr. Devraj for this discussions. Yeah, over to you. He's a pediatric neurologist working with Kim's Cuddles, Secunderabad. Yeah, over to you.
Gayatri ma'am, you can start the proceedings.
Yeah, actually, I had mistaken Dr. Gayatri to Dr. Bhanadeep. Dr. Bhanadeep is an expert, and Dr. Gayatri is the luckiest person today. It's a wonderful, great opportunity for her, and it's going to really boost up her confidence. Sorry, Dr. Gayatri, and over to you.
Thank you, sir. Shall I start, sir?
Yeah, please.
Good morning, everyone. My name is Dr. Gayatri. I'm a final year resident DNB at Yashoda Hospital, Somajiguda. Today, I'm going to present a case. Here is a child, Master D, aged 3 years, 9 months, who is a male, Hindu by religion, resident of Hyderabad, informant being mother, and reliability is good.
Unmute yourself, ma'am.
Dr. Gayatri, it's not audible. Dr. Gayatri, unmute yourself and Dr. Satish, Mr. Satish, you can unmute Dr. Gayatri.
Yes, sir.
Hello, sir.
Yeah, please go back to the first slide, please.
Yeah. So here is a child by name Master D, age 3 years, 9 months, male, Hindu by religion, is a resident of Hyderabad. Informant being mother, reliability is good. Presented with the chief complaints. As the mother noted, the regression of the milestones were noted for the last 6 months in the child, namely unable to climb the stairs, which he previously used to do that, and poor social interaction with the mother and the peer group children, which he previously used to interact with the mother and his peer group children, and their meaningless speech. Previously, he used to speak few sentences. Coming to the history of presenting illness, Master D is a 3 years, 9 months old male child born out of second born out of non-consanguineous marriage, who was apparently well till 3 years of age, and he was able to climb the stairs and was interacting with the mother and was able to speak few sentences and was playful with other peer group children. And gradually, he started losing all his attained milestones for the last 6 months. Initially, mother noticed that the child was not able to climb upstairs, which he used to do before. And later on, in 2 months, he was not able to make eye contact with the mother and stopped interacting with the mother and other peer group children also. And later, gradually, he started with decreasing number of words spoken, and currently he only utters irrelevant single words, and he doesn't even respond to his name now. So as the child has developmental abnormality, I would like to start here only the developmental history. In gross motor, he attained head control at 4 months of age and sits with support at 7 months, and sitting without support achieved at 8 months. He walked with support at 1 year of age and walking without support since 15 months. And he started running at 2 years of age, and he used to ride tricycles and climbed upstairs at 3 years of age, and now he is only able to run but cannot climb upstairs. His developmental quotient is 40%. In fine motor, he used to reach for the objects and grasping with one hand was noted at 6 months of age, and there was a mature pressure gas which is at 1 year of age, and he used to scribble and use a cup by 15 months of age, and he used to copy a circle at 3 years, and now he is only able to scribble, and the developmental quotient for this is 33%. And in social and adaptive milestones, he achieved social smile at 4 months. He recognized mother It is also at 4 months of age, and the stranger anxiety noted at 9 months, and he used to weigh bye-bye at 1 year of age, and hugs parents and complain when soiled at 1.5 year age. Parallel pay with other children at 3 years, and bowel and bladder control were not attained till now. And now he only recognizes the mother and stranger anxiety present, and developmental quotient is 20%. And coming to the language milestones, he started cooing by 4 months and says mama and dada by 1 year of age. There was a jargon speech at 18 months. And he used to name common objects at 1.5 year age, and able to speak a meaningful sentence by 2 years, and repeats 3 numbers by 3 years. But now he is able to only produce sounds and babbles and not able to speak a single word. So the developmental quotient is 13%. And his sleep is normal, and bowel and bladder control has not been attained, and he passes urine 5 to 6 times a day. There is no history of fever, rash, or contact with the TB, and there is no history of seizures, involuntary movements, or altered sensorium. There is no history of gait abnormalities, stiffening of the limbs while changing the diaper or bathing noticed by the mother, and there is no history of abnormal postures or contractures. No history of drooping of eyelids or abnormal movements of the eyes or deviation of eyes. And there is no history of drooling of saliva, and he is able to close his eyes while asleep. There is no history of facial asymmetry or feeding difficulties or regurgitation of the feeds. And there is no history of increase in head size, and no history of tremors on reaching the objects. And no history of yellowish discoloration of the body or abnormal pigmentation of the skin or hair changes. And no history of drug intake, trauma, or recent vaccination. So coming to the antenatal history, the mother is a 27 years old G2P1L1 mother, a non-consanguineous marriage couple. And the first trimester was, first and second trimesters were uneventful. And during third trimester, she had a leak PV at 8 months of age. And the child was born by emergency LSCS in view of preterm premature rupture of membranes. And his birth weight was 350 grams only. The history said that the child cried immediately after birth, and the child had respiratory distress and was on mechanical ventilator, and he received 2 doses of surfactant in view of respiratory distress syndrome. And later he was weaned off to CPAP and HFNC, and all this oxygen support was up to 2 weeks approximately. And later he was weaned off to room air, and the total duration of NICU stay was 1 month, and had a neonatal jaundice on day 3 of life. And he received phototherapy for 1 day only, and there is no history of seizures or fever, and the neurosonograms done at the time of NICU stay were normal. So coming to the nutritional history, a child had expressed breastfeeding was done till 1 month of age, and the direct breastfeeds were started after 1 month of age, and they continued till 6 months of age, and the complementary feeds were started after the completion of 6 completed months. And by 24 hours recall method, his calorie and protein intake showed that he is deficit in calories by 38% and protein deficit by 20%. Coming to the immunization history, he received all the vaccinations up to date according to IAP schedule till now. And family history, there is no history of similar illnesses or seizures or developmental delay or death in the family members. This is the pedigree chart showing that he is born to the non-consanguineous marriage, and he is a second born child. So coming to the socio-economic status, father studied BTech and he's a software engineer now. Mother is studied also BTech. He's a homemaker, and the family income is 1 lakh per month. And according to modified Kuppaswamy classification, he belongs to class 2, which is upper middle class. And the family lives in a Pakka house and uses LPG gas for cooking and has a separate toilet facility, and there is no open air defecation. So coming to the summary at the end of the history.
Dr. Gayatri.
Sir.
Before going to summary,
sir,
shall we start discussion from the history of present illness?
Yes, sir.
Yeah.
Sure.
See, in the history, actually, you said from the birth history, the child is only 950 grams.
Yes, sir.
Isn't it?
Yes, sir.
Then how come the development was normal in the beginning? You said the development till 3 years was quite normal.
Yes, sir.
Isn't it?
Yes, sir.
The 950 grams child, how was the development in the beginning of 6 months of age?
After 1 month of age, he was discharged, and after 4 months only, he had a social smile and recognizes his mother, sir. That was a bit delay, but he achieved within expected time only.
What was the weight gain during the 4 months?
Yes, sir. His weight gain was also like it was initially a bit slow, but later he gained weight, sir.
And in the history of presently, at the end of the history, it should give the inference actually. What was your inference from the history?
So I like to think in terms that even though he is a preterm child with IU, and birth weight was very less, and he had a STOMI NSU course, but later on his developmental milestones were good till 3 years of age, and later on they were in regression state.
Regression started from the age of 3 years, he said, from the
Yes,
history
sir.
wise. And
Yes,
within
sir.
6 months, what was the mental age now at present?
Now, presently, his mental age is corresponding to 15 months only, sir.
15 months.
Yes.
Okay. 15 months. But as you said, the language, out of all the 4 dominants, which is important you would consider?
Language and social.
What is the language now?
Language, he only speaks utterless meaningless words, sir.
Not in sentences.
Not in sentences.
Okay. And history of present tense also should consider like this. Once we elaborated, okay, then you should go into the cardinal symptoms first. What are the cardinal symptoms of this particular system? Okay, and then that cardinal symptom should go in order the way we examine the child.
Sir.
Right? Second thing, etiological history.
Sir.
Okay?
Yes, sir.
Then symptoms suggesting of complications. These are the components. One is elaboration, 2, progression, 3, cardinal symptoms, 4, etiological symptoms, lastly, symptoms suggesting of. Then you should give the inference. That is the way.
Sir.
Okay? Right.
Fine.
Go ahead.
Thank you. So coming to the summary of at the end of the history, 3 years, 9 months old male child born out of non-consanguineous marriage who was late preterm, NSU admission for prematurely with RDS for 1 month and immunized up to date with no significant family history, with a poor nutrition, belonging to upper middle class according to modified Kuppuswamy classification, was apparently normal till 3 years of age. And the later, the child had brought with the complaints of history of developmental regressions in 6 months, predominantly involving the language, motor, and social milestones.
Dr. Gayatri?
Sir.
Yeah, 1 second. So now, according to you, which domain is more affected compared to, or like, is it like motor?
Language and social.
So, like predominantly language and social, is it like regression according to you? So why do you call it as a regression now?
Because initially he used to speak in sentences, but now he is only uttering meaningless words.
So it is like progressing over a span of past
6 months, sir.
So what do you call this progression? Is it like rapid,
like
or
chronic
progressive disorder?
Yes, sir.
Yeah?
Yes, sir.
So
hello. నేను అనంత్ మాట్లాడుతున్నా. వాట్ షీ ఈజ్ ప్రజెంటెడ్ సోషల్ స్మైల్ 4 months డిలేడ్ కదా, హౌ కమ్ ఇట్ ఈస్ నార్మల్ అని ఈయన మాట్లాడలేరు కదా, అందుకని అడుగుతున్నా. సోషల్ స్మైల్ అటైన్ 4 months అంటే ఇట్ ఇస్ అబ్నార్మల్. అప్పర్ లిమిట్ ఈస్ 2, బట్ షీ ఈస్ టెలింగ్ అటైన్డ్ నార్మల్ మైల్ స్టోన్. హౌ ఇట్ ఈస్ పాసిబుల్? Okay.
And that's true. It's in a preterm child. In fact, it's 950 grams child. And that's what I asked her.
Yes. And, 1 month duration was in NSU only, so mother noticed only at 4 months of age.
That too, Gayatri. What about bowel and bladder? Like you were saying, bowel and bladder was not attained till now. At least by 3 years, what should be attained? Like bladder and bowel.
At least he is day by day, at least 3 by 3 years.
So why did he can't achieve that? That what can explain that?
So actually, he used to say that he got wet when he passed urine, sir, previously. But now he lost that also.
That he didn't achieve at all, no, till now. So that is somewhat like we can't explain, no, why did he at least by 3 years of age he should be at least dry by day at least, if you
Yes,
say.
before he used to do that, sir. I mean, sir, he used to tell that that the pants were wet and please remove, like that he used to say. But now it was lost.
It was lost.
He won't even say that. Mother only will notice the diapers and she will change.
Okay. Then you once go to the like previous slide, no, about negative history. Yeah. So why did you ask about any history of rash and all? Like, can you please tell
These
us the reason for?
precipitating illnesses, sir, these will
Okay. Is there
preceding,
any? Yeah.
like measles. If it is there, then the child will have like subacute sclerosing panencephalitis, like that.
Okay. Any other thing? But SSP.
Meningitis.
Okay. Rash thing. Why did you ask initially? Any other
But,
thing that you want to rule out? Any
uh,
other disorders of like pertaining to rash with some regression?
Rubella.
No. No, you are talking about only infections, no, like things, something coming to neuro regression, you are saying. So,
Okay. Yes.
and yeah, also you have to ask about, because you should think of any vitamin deficiency also when if a child has some rash or any skin
Yes.
or some because the child has some regression, it can also be some kind of cocaine syndrome also. So if anything you should think of that one also, because at 3 years old that child can present like the same thing only. Okay.
Okay.
And go to the next slide. So here, why did you ask about increase in head size and all? What are you ruling
The
out?
cranial nerve disorders, sir. I want to rule out the cranial nerve involvement.
No, increase in head size. What does
Head size is anencephaly. And sorry, I mean macrocephaly. I used to say.
macrocephaly you want to rule out? Okay. Are there any other things that you want to rule out? No, because the child had some regression. Also, child had previous NSU stay and all. So, like also there can be one history of hydrocephalus previously, because the child also is
Yes, sir.
precipitation. So that
Yes.
can also can be normal till that day, and that child might also can regress like
Yes, sir.
gradually also. So
Yes,
also
sir.
to roll out some history of hydrocephalus or like pertaining some vomiting also. You have to think
Yes.
of any vomiting or any signs of ICP. You have to ask actually.
Yes,
Because
sir.
sometimes intracranial mass per se can cause regression.
Regression. Yes.
That also you should ask also. And okay, yeah, next slide. So why did you ask about this discoloration of body and all? If there is
Yellowish discoloration to rule out jaundice, and it is seen in Wilson's disease also. Sometimes this neuroregression will be present in a future.
But less than like 4 years.
4 years, it is uncommon, but
Okay.
yes.
Okay. In like what drugs you are asking here? Any history of drug intake
Like
and
anti-epileptic drugs like phenytoin, carbamazepine.
why so? That will cause regression.
Yes, sir.
No.
Like long-term use, they will cause there is a study that they will cause a neuroregression also.
Neuroregression is like gradually so much. Then some other drugs, it is like what is that called? That's due to pseudo regression, no?
Yes, sir. Yes.
Okay. Then what about this trauma? Why did you ask about trauma and all?
Trauma leading to any intracranial hemorrhage which will be again leading to neuroregressions.
What are the diseases that will progress after some trivial trauma and all? Can you give some examples?
No.
This same normal child, they will have some regression after some trivial trauma and they will progress gradually. So certain diseases like mitochondrial spectrum per se can manifest like this, and also certain diseases like Van der Nap or vanishing white matter disease per se can form like this also. Like after some trivial trauma, they will regress gradually. So that you should keep in mind. Okay, yeah. Next slide. Okay, yeah, it's fine.
So coming to the general physical examination, the child is awake and he was lying on mother's lap and was not maintaining eye contact. There is no pallor, icterus, cyanosis, clubbing or lymphadenopathy or edema. And vitals for his temperature, he is at 98.4 degrees, half febrile, and pulse rate for 84 per minute, normal in rhythm and normal in volume and character. And the pulse is felt in all peripheral pulses, and there is no radial delay or radiofemoral delay. And blood pressures were 94/60 millimeters of mercury in the right hand supine position, corresponding to 50th and 90th centile, and respiratory rate was 22 per minute, thoraco-abdominal type, and saturations maintaining 98% on room air, and capillary filling time is less than 2 seconds. And anthropometry, and his weight is underweight and length stunted, and weight for height is normal, and mid-arm circumference is normal, head circumference is normal, and he is a chronic malnutrition. And head to foot examination, the head appears normal in shape and the AF is closed, and the hair appears normal. There is no facial dysmorphism. Ear, nose, mouth and normal, and eyes are normal. Neck appears normal, and there is no chest deformity, and trunk is normal. And skin examination, it is normal. There is no hyper or hypopigmentation, no bed sores or contractures, and no neurocutaneous markers, and BCG scar present. And examination of the nervous system, the child was awake and there was no eye contact and speech is incomprehensible. And the cranial nerve examination, first nerve could not be tested, and second nerve.
Dr. Gayatri.
Sir.
What is the handedness in this child actually?
Right-handedness, sir.
Right-handed, okay.
And cranial nerve exam.
We are going very fast. Little slow.
Okay,
your presentation is a little fast.
Okay, sir. Okay, sir. And the cranial nerve examination, first nerve could not be tested. Second nerve, visual acuity, he is not able to fix the to any object and follow the objects. Visual field could not be assessed, and color vision also could not be assessed. And bilateral pupils equal and reacting to the light. Fundi are normal. And 3, 4, 6 nerves, extraocular movements are normal. There is no squint or nystagmus, and there is no ptosis. And fifth nerve, he is able to appreciate pain over the face, able to chew food. There is no deviation of jaw to any side. Seventh nerve, he is able to close his eyes tightly. Forehead wrinklings are noted. There is no deviation of angle of mouth, and nasolabial fold present on both sides. Eighth nerve, he is not responding to the sounds or voice. And 9th and 10th nerves, uvula is in midline. No, there is no pulling of secretions and gag reflex present. 11th nerve, he is able to turn head sideways. 12th nerve, there is no deviation of the tongue, or there are no fasciculations.
Can you repeat the previous slide, Dr. Gayatri?
3, 4, 6, sir.
No, previous, next. Oh, yeah, no, next, previous slides. Yeah. Okay. What is your inference from the second now?
His visual fixation is not there, sir, now. He's not able to make eye contact.
Right.
And his fundus examination is normal. And pupils are bilateral and equally reacting to light.
No, what is the visual? How is the visual acuity? Vision is there or not? You said not able to fix, but how is the vision actually?
he's not able to make eye contact even with the mother also, sir. So I think it
Okay.
is less.
You said bilateral pupils are equal and react to light, but vision is intact or not?
Vision, like
What test you do in this condition? Did you did menacing technique?
Menace reflex, yes, sir. Menace reflex is present.
Okay. Suppose menacing reflex is absent and bilateral pupils are reacting to light. What is your inference? It's a cortical blindness. What is the cortical blindness? Cortical blindness. Okay. You got it?
Yes, sir. Yes, sir.
Right.
Occipital
Next slide. You can go ahead. You said eighth nerve is not responding to sound.
Yes, sir. Yes, sir.
How could you assess the speech in this child?
He was only blabbering at that time, sir. So we just heard
assessing the speech. How do you assess the speech in such child? You said he's not able to understand.
Relevant words
he's not
he
able to
speaks.
hear, isn't it? Okay. Right, go ahead.
In motor system examination, the bulk was normal in mid-arm, mid-forearm, mid-thigh and mid-calf bilaterally. And the tone, while doing passive movement, we noted that there is a decreased movement in all limbs. And power, neck, he is able to turn sideways, and in supine and prone position, he is able to lift the head of the bed, and abdominal muscles, the child was able to get up from the bed. Trunk, he is able to turn side by side, and the bilateral upper limbs, shoulder, elbow, wrist, knee, and maximum observable power was 3/5, and bilateral lower limbs also maximum observed power was 3/5. And reflexes, superficial reflexes in corneal conjunctival could not be tested, and abdominal reflexes are present, and cremastic reflex is present, and plantar bilateral extensor noted, and primitive reflexes were absent. Deep tendon reflexes, biceps, it is 2+, both sides, and triceps are also normal, supinator normal, knee jerk is 3+, and both right and left side. In sensory system, he is able to appreciate the pain, and the touch and temperature could not be tested. Cerebellar signs, there was no nystagmus or no pendular knee jerk or no intentional tremors. Other signs could not be elicited, and skull and spine are normal, and there are no signs of meningeal irritation noted. So, coming to other systemic.
One second. So, like, what reflex you check for actually in case of primitive reflexes?
Suck reflex and palmomental reflex.
Okay, and are they absent?
Yes, sir.
Then what else did you check? What are the like other primitive reflex that you should look for in case of if you think of neuro?
Moro reflex.
Okay.
I would look for palmar and plantar grasp.
You should look for,
yes,
no?
Palmar and plantar grasp.
Yes, sir.
Is it present?
No,
it present?
sir. No.
Okay. So no neonatal reflexes. No primitive reflexes.
No primitive reflexes, sir. Yes.
They should appear, no. And it's your entire history is giving regression. And definitely there some primitive reflexes has to appear by this age.
But they were not noted, sir, in this child.
Okay.
Okay, one more, Gayatri. And based on your history, like you are saying the tone is decreased, no? like hypotonia with but plantar was extensor. So what is your inference based on it?
In passive movements, the tone was hypertonia only, sir. We noted hypertonia.
You are saying decrease in passive movements, no?
Yes, sir. When we are doing that roll over the test, the movements were slightly decreased. So it is a hypertonia.
Okay, okay. So hypertonia, okay. Okay, yeah.
So other systemic examination, CVS normal heart sounds per heard, and respiratory wise bilateral normal vascular breath sounds heard equally on both sides, and the per abdomen soft, there is no organomegaly. And coming to the summary, 3 years 9 months old male child, second born to non-consanguineous marriage parents, with NSU admission for respiratory distress syndrome. He was developmentally normal till 3 years of age, and now presented with the insidious onset of slowly progressive neurological disorder in the form of regression of the attained milestones, namely language, social, vision, and hearing and motor milestones, with the hypertonia noted on examination without any encephalopathy features and without the involvement of cranial nerves. And there is no organomegaly also, and the head circum a normal general physical examination and with no significant family history and with moderate acute malnutrition also.
Saying that he cannot fix and follow, no? So what about the second nerve? Is it involved or is it not involved? Even the hearing also.
Second nerve, it is second nerve is involved because he is not able to fix the objects. Visual fixation is not there.
And what about eighth nerve?
Eighth nerve also, he is not able to turn, even when his name was called, not able to turn to sounds and voice also.
But here you mentioned there is no involvement, so that's why I'm just asking.
Yes. Okay, sir. Yes.
And okay, yeah. So
how do you put the clinical diagnosis now? Dr. Gayatri, how do you put the clinical diagnosis?
So initially the child his developmental was normal, and now he was in regression phase. So I would like to think like it is a neurodegenerative disease with neuroregression, and social and vision also decreased. So it can be like autism also, but motor component is involved. So I would like to think only in terms of neurodegenerative disease.
No, say clinical diagnosis. So you said there is a tone is increased in all the 4 limbs and detail is exaggerated. So do you say is it a quadriparesis in this child?
And so not fully developed, sir, actually.
No. Is it there is a weak according
Yes,
to you, there is a weakness in all the 4 upper and lower limbs.
Yes, sir.
So is it quadriparesis?
So spasticity I can think of.
That's what is it. Tone is increased.
Yes.
As I said. So tone is increased, power is decreased, and DTR exaggerated. So all EMN lesions are there.
Yes.
Isn't it? So it's a quadriparesis of EMN type.
Yes.
Okay. And you are saying is a spasticity. Is it spasticity or rigidity? How do you differentiate it?
Spasticity, like the total movement, at the end of the movement, there will be like tone will be increased, and the rigidity, the entire movement will be
okay,
like
that's one picture. Next, Any other features? Any other features to differentiate? So your clinical diagnosis directly put into a regression now. Findings on the examination, you put it as a clinical diagnosis. It's a chronic, progressive analysis of EMN type with a second and eighth nerve involvement, according to you, isn't it?
Yes, sir.
Then etiological diagnosis. Etiologically.
So as so etiologically, I think it is a white matter disease involving white matter lesions.
Okay. Then no, you can etiologically you can do the differential diagnosis also, isn't it? But the various causes where it involves in white matter degeneration.
So white matter disorder also, and the head circumference is normal. It will go in with the adrenoleukodystrophy or metachromatoleukodystrophy. If there would have been a macrocephaly, I would like to think of Alexander and Canavan's disease. And if there is a microcephaly, I would like to think of Krabs disease.
But here head circumference is normal, you said.
Yes, sir. Yes.
Where do you put the lesion in this child? Anatomically, where
The posterior part of the cerebrum, I mean white matter involvement.
why posterior?
Because the vision and hearing were lost.
Okay. So white matter degeneration conditions which are occurring at the age of 3 years manifesting. So what are the different causes?
In white matter disease, they will be like demyelinating and dysmyelinating disorders. So demyelinating will be, there will be a previously normal myelin sheath, and because of a immune reaction or a toxic exposure, there will be loss of myelin. And the causes of the demyelinating disorders will be multiple sclerosis or Schiller disease. And the other cause of white matter disease is dysmyelinating or hypomyelinating disorder, where there will be abnormally formed myelin sheath consisting of either abnormal biochemical composition or defect in the myelin formation, and which is again depending upon the head circumference, it is divided into 3 types. Like if it is involving macrocephaly, then it will be like Alexander and Canavan disease, and if it is a normal head circumference, it will be like Alexander and adrenoleukodystrophy and metachromatoleukodystrophy, and it is if it is with associated with microcephaly, then it will be like Krabs.
But does the family history supporting in this case?
No, sir. There is no history of similar complaints in the family members, and there are no history of sudden deaths also in the
your diagnosis, isn't it? One of the features is against. Any other possibilities we can think of?
Right. No, sir.
Okay. So how do you investigate this child?
Sir, hello.
How do you investigate this child to confirm your diagnosis?
Yes, sir. Actually, first we did the normal examination with the complete blood picture and RFTs, electrolytes, LFTs, and which were all normal actually. And later we did the MRI brain, and which showed this first image is a T2, diffusion weighted image, which showed periventricular peritrigonal white matter in hyperintensities, and this is a T2 flare image, which also showed the periventricular white matter involvement. And later we did the BERA, which showed a bilateral profound hearing loss, and the fundus examination was normal, and the visual evoked potential showed anterior visual pathology. And we have sent a whole exome sequencing and very long chain fatty acid levels also, and the reports were awaited for this child.
No, there's a hearing loss, cortical blindness, premature child. Is it cerebral palsy?
Attainment of milestones will be.
What are the points against for cerebral palsy here?
First, he attained milestones. Later, he started regressing. So, in cerebral palsy, the attainment of milestones will only be delayed, actually.
Okay.
Dr.
Any other differential diagnosis you can give?
Sir?
Any other differential diagnosis you can think of?
Autism also, sir, for this child.
Okay.
And attention deficit disorder also. Regressive autism.
Then how do you explain quadriparesis in autism?
Yes, that is the against point actually for the child.
I think Bhanudeep sir will.
Gayatri, did we what you will do if you think of some aggressive autism that you are saying? No, what you should do to pull out it?
Sorry, sir, I was not able to hear.
If you think of regressive autism, what you should do to pull out it? What investigation you should do? Like if you think of some LKS, Landau-Kleffner syndrome and all, I was saying the child had some regression and all, no? So what you should do to rule out? You should do an EEG, no?
Yes, EEG, yes, sir.
EEG, in EEG, what
EEG was normal, sir, in this child.
It was normal.
Yes.
No, if it is LKS, what you will find in the EEG?
Sorry, sir, in which?
If it is Landau-Kleffner syndrome or regressive autism, that what you are saying, what you will see in the EEG?
Seizure activity.
Mostly you will see during the sleep actually. During the sleep, there will be more increase in the IADs.
Okay, sir.
That will call is is also called as ESCS pattern that we will call as. So that usually we'll see in the EEG if it is like LKS or regressive autism. And so in this child with normal, now what is your diagnosis now? Where like final diagnosis?
Like final diagnosis, the neurodegenerative disorder with normal head circumference. So, and I would like to think with adrenoleukodystrophy or metachromatoleukodystrophy. Sir.
Okay. So in this child, was there any like pigmentation of skin?
No.
No.
There is no hyperpigmentation.
So
So,
what are
in adrenoleukodystrophy, the first neurological involvement can also be seen without the involvement of adrenal glands also.
Yeah, what is the various types of presentations in that you will see in ALD?
In
Whereas that you were saying, no, it can involve
yes,
without adrenal glands. Then what else?
adrenomyeloneuronopathy,
Okay.
early cerebral adrenoleukodystrophy, and infantile onset adrenoleukodystrophy.
Okay. So it can present as only Addison's anemia also. Addison's
It's
gland.
only Addison's disease also possible. In 25% Addison's diseases, X-linked ALD can also be possible without involvement of neurological signs.
Can present without adrenal gland that you told. It can
Yes.
only involve a brain as well.
Yes, sir.
So, and also like what you told in the spinal cord, when you will see that adrenomyeloneuropathy, at what age?
In adult, it is common in adult age. Like 30 to 40 years of age, it will be seen.
Okay. And like in women, what you will see? Involve women or will it won't involve women?
Sir?
The mode of inheritance is like autosomal dominant or
It is
autosomal
X-linked. X-linked, sir. In women, it is a carrier state. Heterozygous involvement.
X-linked dominant or
X-linked recessive, sir. It is a X-linked recessive disorder, and
Okay.
woman will be a carrier.
Okay. So it will in women it will manifest or not?
No, sir. If both the parents are recessive, then it will manifest.
In what way? In women, there are specific findings that you will see in case of ALD. It won't be like adrenomyeloneuropathy and all.
Sir.
They will have some premature ovarian failure, like that. In present actually. So that we should keep in mind.
Okay, sir.
So so what about like what other think of like I know it's like ALD you told one. So what other DDs that you will think of with normal head?
Metachromatoleukodystrophy also.
MLD.
Gayatri,
Okay.
is there any scope for CSF analysis in view of MLD?
Yes, sir. High proteins will be noted in metachromatoleukodystrophies.
Have you done in this case?
No, sir, actually.
Anything? What else you look in CSF? These proteins then? We'll see metachromatic granules.
Granules, yes, sir. Okay.
Okay.
I just made slides regarding neurodegenerative disorders also.
Can you show this patient's slides actually? How he looks, you know? Do you have
Actually,
pictures?
no, sir, actually.
Oh.
No.
Why? How come you missed? could have shown the.
Actually, I have taken, but it was last, sir. Actually, I couldn't regain it. Sorry.
At least you would have seen the how his patient looks, isn't it? Okay.
So,
You want to show the slides? Okay.
so
Yeah.
just a
Yeah, yeah.
mention about neurodegenerative disorders.
Right.
So these are a group of disorders where there will be progressive damage to the brain with or without involvement of the systemic involvement, and many of them will have a genetic basis while a very few will be acquired, and they are characterized by progressive loss of previously acquired skills or milestones, or progressively decreasing rate of acquisition of milestones. And the basic approach is by like if it is a neurodegenerative disorder or not, and is it involving a gray matter or white matter problem, and identify the systems involved. And to say that it is a neurodegenerative disorder, there will be early normal development, and there will be regression or slowing in the rate of acquisition of new skills later on, and there will be a progressive course of deterioration, and the duration will be greater than 3 months of age, and it can be present as acute encephalopathy features or chronic diseases. And acute encephalopathy neurometabolic disorders will be like maple syrup urine disease, or organic acidemias, or lactic acidosis, or urea cycle disorders. And the chronic course will be sphingomyelipidosis or mucopolysaccharidosis, or glycoprotein degradation disorders, or peroxisomal disorders, and fatty acid oxidation defects also, and neuronal ceroid lipofuscinosis also. And family history may be positive in the neurodegenerative disorders, and there will be no evidence of intracranial infection or space-occupying lesions. And whether it is involving later, after confirming that it is a neurodegenerative disorder, we will see whether it is involving a gray matter or white matter disease. And to say that it is like features of dementia or cognitive decline will be early noted in gray matter disease, and seizures will be involved early in the gray matter, and the spasticity and hyperreflexia due to long track involvements will be seen in early in white matter disease, and the peripheral neuropathy will be seen in white matter diseases, and involuntary movements will be early in gray matter diseases, and head size will be usually microcephaly in gray matter diseases, and may have megalencephaly in white matter diseases. And when you do a visual evoked potentials or BERA or electroretinography, which will be normal in gray matter disease, there will be abnormal in white matter disease. And later you should identify that if it is involving other systems or not. This is a slide showing the differences between white matter and gray matter disorders. And the age of onset will be usually late in white matter diseases and usually early in gray matter. And the head size will be usually megalencephaly, may have megalencephaly in white matter and usually microcephaly in gray matter. Seizures will be late onset in white matter and early onset in gray matter. And cognitive functions will be initially normal in white matter and progressively decline will be there in gray matter. And peripheral neuropathy will be early in white matter and it will be late in gray matter. And reflexes will be, if it is a neuropathy, then it will be absent, and if it is involving long tracks, they will be exaggerated. In gray matter, it will be normal, and the cerebellar signs will be early prominent in white matter and will be late in gray matter. EEG will be showing diffuse delta waves flowing in white matter and epileptiform discharges in gray matter. EMG will be slowed nerve conduction velocity in white matter and usually normal in gray matter, and same with visually evoked potentials and ERG. ERG will be abnormal in gray matter. And depending upon the age of onset of the disease, if it is if the child is less than 2 years, and if it is associated with hepatomegaly or hepatitis effects, then we can think of conditions like fructose intolerance, galactosemia, glycogen storage disorders, mucopolysaccharidosis, Niemann-Pick's disease, Zellweger's, Gaucher's disease. And if it is without organ hepatomegaly, then It can be Crab's Rett's maple syrup urine disease, Menke kinky hair disease, Tay-Sachs, GM2 gangliosidosis, SSP, and Canavan's disease are neurodegeneration disorders of the brain. And if it is involving 2 to 5 years of age children, then Niemann-Pick's type 3 and 4, Wilson's disease, neuronal ceroid lipofuscinosis, mitochondrial encephalopathies, ataxia telangiectasia, neurodegeneration with brain iron accumulation syndrome, metachromatic leukodystrophy, adrenoleukodystrophy. If it is involving 5 to 15 years, adrenoleukodystrophy, neuronal ceroid lipofuscinosis, adult forms, and Refsum's disease and the sialosis. So, a few slides about X-linked adrenoleukodystrophy, that the incidence will be 1:20,000 male births, and there will be defect in ABCD1 gene, which leads to the deficiency of peroxisomal membrane protein, which leads to the impairment of beta oxidation of very long chain fatty acids, which leads to the accumulation of very long chain fatty acids in white matter and in adrenal cortex and also in testes. There are 5 types: classic adrenal leukodystrophy, adrenal myeloneuropathy, adolescent cerebral, adult cerebral, and Addison's disease. So the clinical features in them will be, the child usually will have normal development till first 3 to 4 years of age, and the onset will be noted at 4 to 8 years of age with behavioral problems and school failure and rapid deterioration of the auditory discrimination, spatial disorientation, speech and writing, and seizures in 30% children, and there will be a rapid deterioration of the gait to the spastic paraparesis and swallowing difficulty, pseudobulbar palsy, and visual loss, and progression to vegetative state within 2 years of age of onset, and there will be abnormal skin pigmentation and adrenal insufficiency noted in them. So investigations, MRI will show symmetric white matter lesions involving the periventricular matter in the posterior and the parietal occipital lobes, which it is seen in this child also. And MR spectroscopy will show decreased neuronoaspartic acid and increased choline levels. And astoaspartate, sorry. ACTH will be elevated in greater than 85% children, and very long chain fatty acids, it is the most specific test for this, and high levels will be noted in the plasma. And the treatment for this condition will be corticosteroid replacement therapy if there is an adrenal insufficiency, and Lorenzo's oil, it is not approved therapy, but is in pre-symptomatic children they are used. It is nothing but 4:1 ratio of a glyceryl triolate and glyceryl triuricate oil, and there will be early neurological. If there are early neurological signs, consider bone marrow transplantation. And the experimental therapies are used with the lovastatin and gene therapy. Coming to metachromatoleukodystrophy, it is an autosomal recessive disorder where there will be a deficiency of aryl sulfatase A, which will be leading to demyelination, and the gene located will be on long arm of chromosome 22. And 3 types of MLD are late infantile form, juvenile form, and adult form. Incidence is 1:4,000 children, and the clinical features, the gait disturbances, ataxia, hypotonia will be there. And in later stages, there will be decerebrate posturing and optic atrophy and loss of speech also. And usually the children will die between the age of 3 to 7 years. And investigations, we will do urine for metachromatic granules and nerve conduction velocities. CSF reveals high proteins. And sural nerve biopsy will show sulfatides accumulation in the macrophages, and the enzyme assay and molecular analysis. MRI will show hyperintense signal in periventricular and central white matter in the T2 images, and the treatment will be bone marrow transplantation only. Thank you.
Good. No, Dr. Gayatri.
Sir.
Now, finally, what is your diagnosis in this child?
We are considering adrenoleukodystrophy only, sir.
Adrenoleukodystrophy. But family history, there's no suggestion of similar illness in the family. No, you have taken 3 generations.
Yes, sir, 3 generations.
But still,
yes,
you said it's an X-linked.
Yes.
Isn't it? But still, we don't have any evidences.
25%.
Have you done ACTH in this child?
ACTH levels were we didn't do in this child, sir.
Why? How come?
The adrenal involvement was not there. Like electrolytes were normal, RFTs were normal,
Okay. Okay.
and there is no skin rash also. Hyperpigmentation changes were not noted.
There are many features against for ALD also.
Yes, sir.
Still, final diagnosis we had to confirm from the
Whole exome sequencing and very long chain fatty acids are awaited. If they are positive, then it is a adrenal leukodystrophy.
very good presentation. Good. You're given a good information.
Dr. Gayatri,
Sir.
if it is ALD, then what is your plan for this child now?
Sir?
What is the next plan? Like if it is ALD, then what is your plan for this child?
So first we will treat the symptomatic treatment of the child. If there are any associated symptoms and
like what symptoms you will treat? Symptomatic treatment means what will the child have? So now the child is like 3 to 4 years, no? So
yes, sir.
Start from here only, and then slowly the child will have like decrease in the school performance and all, and then gradually it will progress. The child might have some seizures also, and slowly he might.
For seizures, we will give anti-epileptic medications.
Okay.
And
so, if it is ALD, what is the next plan? Like, how do you manage?
Rule out adrenal insufficiency first. If it is there in adrenal insufficiency, we will start on corticosteroids and then follow up closely with the neurological assessment. And if the child is worsening very early neurologically, and if there are worsening neurological features by MRI also, we'll consider early bone marrow transplantation for this child. And
this child is, if it is ALD, actually it's like a candidate for BMT actually.
BMT, yeah.
Because as soon as possible. You can't wait till 6 to 7 years. So most of the children usually will do MRI and we'll have some score also. It's called as Lewis score. So if Lewis score is less than 16, then you can do BMT ASAP actually. Like you can't wait till that time. So like BMT is actually it's like a life-saving thing for the case of ALD.
Yeah.
So after BMT, if we do early, they will even become normal as well. So we can't delay that. That's what I want. That's what I want.
Yeah. Yes. That's our plan. We are waiting for the sequencing as well as we are very long chain fatty acids. The turnaround time for very long chain fatty acids is 1 month from our lab. So we are waiting for that.
Okay. Yeah. It's very good.
Basically, this child is one of our consultant follow-up. The child was following with Dr. Suresh since 1 year of age. So though the child had significant neonatal history, he was a late preterm, 34 plus, IUGR, but neurologically normal. At the time of discharge, child was discharged on direct feeds. And there was never history of any critical difficulties, never history of any tone changes, no sleep or behavioral pattern disturbances. There was no history suggestive of any static encephalopathy or any significant brain involvement at the time of birth. So then 1 year onwards, he was in follow-up with Dr. Suresh. Then the child was normal, growing all milestones attained at the normal age, except for the initial social smile. That was a history. We don't know whether the child was smiled early or not, but since 1 year of age, all the milestones were in normal pace. So at the 3 years of age, he started losing all the milestones. Then now also clinically, the child, as Dr. Gayatri mentioned, the tone changes. We were not able to assess her child's power exactly because he was not cooperating. That's why we said the maximum observed power is more than 3, but it is not 3 or 4, because he was able to move, he was able to walk, but when we ask him to do active movements or against resistance, he's not doing, because he's not following with us commands. But only subtle changes were there. Neurologically also, subtle changes in tone. There was hypertonia and reflexes were exaggerated. Other than that, no other neurological findings in this child. So more of language, social milestone involvement. Then hearing and speech was bilateral profound hearing loss was there. He was not at all responding to our call. And it was proven by Bera also. Then so we were ruled out. Menace was positive. Occipital blindness was also considered one of the things when he was not normal pupil reflexes with positive menace reflex, and he's not following. So we consider all these things into consideration. And so as per history, we were like neuroregression was confirmed. Then anatomical, we were localized to white matter signs only. Other than that, nothing was there. So MRI was the breakthrough for us. So unless until MRI comes, we were not able to tell what it is exactly. So once the MRI was done, and where there was parieto-occipital changes, so then we started considering all the findings. There was no other extra CNS manifestations, no organomegalies, and normal head size being normal. So then we were able to pin down to ALDs.
So actually, sir, ALD is like a close mimicker to like many things actually.
Yeah,
because ALD doesn't only has vision loss, only has hearing loss without any.
Yes. Yes.
So early, like if you want to so too early to comment is very difficult also. So
Yes.
only MRI will give us clue. MRI also
Yes.
is like too early to comment. It's not like fully also it's not fully. So like 3 to 4 years, most likely if we did it too early, it's like even better for the child also.
Yes, yes. Thank you for any other comments, sir. Anything we missed in this case, please suggest any changes or anything we would have done very early, sir, clinically or else investigation wise.
No, it's very good workup, Dr. Jeevan Reddy. A very good workup you have done. What the way you went is good. A good presentation also. Okay.
Thank you, sir.
Thank you, sir.
Yeah, thank you very much. And it was a masterly discussion went on between the lead discussants, presenter, and the mentors. Special thanks to Dr. Devaraj and Dr. Bhanudeep with their wisdom. They had conducted so well, so softly, encouraging the PG student. That shows the experience and the encouragement to the upcoming students. And really, even for me, the case was very interesting, very informative, very educative. I'm sure Dr. Jeevan, then Dr. Samatha, they worked so well in cohesion and made it a very good presentation. I mean, we were trying to find out some lacunae. Of course, I'm a practicing pediatrician. Even for me, even for the experts, they could not find major lacunae. So very well presented. And it's now earlier we used to think it's only Nilofer, Gandhi, but of late so many hospitals are coming up with so bright students, with bright faculty. It gives us an immense pleasure. Today we have less attendees. Probably the reason is it's being recorded on YouTube. Maybe they'll be watching at their convenience. So once again, I thank all. And lastly, my apologies to Dr. Bhanudeep. I was a little confused. You being an expert. Yeah? Yeah, thank you very much. Hope you understand me. And Dr. Gayatri, you had presented so confidently, so well, and I'm sure you'll. And your examiners had appreciated your presentation. That means you had cleared your PG exam.
Thank
Yeah.
you, sir.
I thank all the participants.
Thank you, Dr. Bhaskar.
Yeah, thank you, sir. Thank you all the participants. Dr. Anand sir, and
Yeah.
others. Thank you. Thank you.
Thank you, sir. Thank you for the opportunity, sir. Thank you.